The next part of cardiac disorders that we're going to talk about is cardiac dysrhythmias and myocardial infarction. It might be two separate sections. We'll see. So cardiac dysrhythmias fall in the category of electrophysiological problems, and myocardial infarction is usually a vascular problem. So let's talk about it. So the learning objectives, I don't know why I have these backwards from the way I have the PowerPoint, but there you go. Identifying the causes and treatments for angina pectoris, and we'll talk about what angina is. Describing the basic pathophysiology of a myocardial infarction, differentiating angina from myocardial infarction, important. List and briefly explain 3 possible causes of cardiac dysrhythmias, and define shock and describe why it can happen in myocardial infarction. So just a little bit about cardiac dysrhythmias, a little bit about myocardial infarction, and we'll just go right into it. So cardiac dysrhythmias, also known as arrhythmias, are deviations from normal cardiac rate or rhythm. So they can be caused by different things. They can be caused by electrolyte abnormalities, like high or low potassium, fever, hypoxia, stress, infection, drug toxicity. External electrical shock could also cause cardiac dysrhythmias. Electrocardiography for monitoring the conduction system detects abnormalities in the heart rhythm. So when you have abnormalities in the heart rhythm, it reduces the efficiency of the heart's pumping cycle. So there are lots of different types of abnormal conduction patterns, and we'll talk about some different ones and why they are a problem and which ones are the most dangerous. So sinus node abnormalities, the SA node, the sinoatrial node, is the pacemaker of the heart. And its rate can be altered by mostly sympathetic nervous system input. Bradycardia is a regular but slow heart rate. Tachycardia is a regular but rapid heart rate. So usually bradycardia is anything below 60 beats per minute. Tachycardia is usually above 100 beats per minute. Sick sinus syndrome is marked alternating between bradycardia and tachycardia. So your heart can't decide what it's going to do. Your sinoatrial node can't decide. It often requires a mechanical pacemaker because your internal pacemaker, your sinoatrial node, is not working correctly. So you need that extra help from the mechanical pacemaker. So you can have atrial conduction abnormalities. So these are 3 different ones. Premature atrial contractions or beats. So sometimes they're called PACs for premature atrial contraction, or PAB for premature atrial beats. There are extra contractions or ectopic beats. And sometimes it's caused by irritable atrial muscle cells outside the conduction pathway. So instead of just contracting when the sinoatrial node tells them to, they're contracting outside of that normal conduction pathway. So you can see how that would cause a problem, because the atria have to contract and then relax, and then the ventricles contract and then relax, and then the atria contract and then relax. So if they're contracting when they're not supposed to be, that can cause a problem with blood flow. Atrial flutter is considered an atrial heart rate of 160 to 350 beats per minute. I have seen some updated material that gives some different definitions of atrial flutter and atrial fibrillation, and I'm not going to expect you to know the numbers, but I just want you to know kind of the difference. So atrial flutter is fast atrial extra contractions, and atrial fibrillation is even faster. So atrial flutter is the AV node delays conduction. So the ventricular rate is slower than the atrial rate. So it causes a problem because the atria aren't they're going too fast and they're not filling enough to fill up the ventricles. So it's going to slow down and decrease your cardiac output. There are videos in the PowerPoints that you can watch that show atrial flutter and atrial fibrillation. We'll watch them in class. So atrial fibrillation, or sometimes it's called AFib, is an atrial rate of over 350 beats per minute. It causes pooling of blood in the atria because it's going so fast, it doesn't have time to shoot that blood out into the ventricles. There's a risk of thrombus formation because it causes turbulence in the blood that's in the atria. And so your atria can throw a clot and it can go into your, depending on whether it's the right or the left atria, it can go into your pulmonary or your systemic circulation, and that could be a problem. So there's a surgical procedure that they use sometimes for atrial fibrillation that's called the Watchman, and it's a little, I heard a cardiologist describe it, and it's almost like a little cap that goes on the inside of your atrium and keeps it from fibrillating, and it keeps blood clots from forming in there. So that's kind of a new procedure that they use for AFib to prevent clot formation. I think that's interesting. So they're always coming out with new things. Isn't that great? Coming out with new things. So atrial flutter and atrial fibrillation are a problem because of that pooling of blood in the atria and decrease of cardiac output. Atrioventricular node abnormalities are called heart blocks. And I don't expect you to know the little poem or anything. I just thought that was funny. Put it in there. So conduction is excessively delayed or stopped at the atrioventricular node, or the bundle of His, it's also called. First degree block is where there's a conduction delay between the atrial and ventricular contractions. So remember, they have to be coordinated, right? The second degree block is every second to third atrial beat is dropped at the AV node. So now things are out of whack between the atria and the ventricles. A third degree block is there's no transmission from the atria to the ventricles. So that's a big problem. That, you know, we're definitely into some serious problems here. So a bundle branch block is interference with conduction in one of the bundle branches, the ones that branch off the atrioventricular node. Ventricular tachycardia is likely to reduce cardiac output because you get reduced diastole because the ventricles are going really fast, so fast that they don't have time to relax. And so they don't have time to relax and fill, and so they're shooting out less blood with each beat. Ventricular fibrillation is where muscle fibers contract independently and rapidly. They're not even listening to the AV node, and this is the one that can kill you. Cardiac standstill occurs if it's not treated immediately. So if you're using an AED, an automatic external defibrillator device, which most public places and clinics and everything have these days, and you put it on and it's analyzing the rhythm, if it detects ventricular fibrillation, it is going to recommend that you shock the person, because your ventricles have to be restarted or you're going to die. So that's a big problem. Premature ventricular contractions, or PVCs, are additional beats from the ventricular muscle cells or ectopic pacemaker that may lead to ventricular fibrillation. So you can have just the odd off PVC and it's not going to be a problem, but if it keeps happening, it could lead to ventricular fibrillation. So ventricular fibrillation is the most dangerous cardiac arrhythmia because the ventricles stop relaxing enough to fill, and it cuts down what's going out into the pulmonary and systemic circulation drastically enough to kill you. So ventricular fibrillation, if somebody asks you someday, what's the most dangerous cardiac dysrhythmia, ventricular fibrillation is the answer. So this is our little chart. You know how much I love the little green and white charts. So bradycardia is a regular rate, but slower than 60 beats per minute. And the effect of bradycardia is that the stroke volume is increased because it's slow. It really has time to fill. But you're going to possibly reduce your cardiac output because remember, cardiac output is heart rate times stroke volume. So you have low heart rate, even though stroke volume is increased. If the heart rate's low enough, we're possibly going to decrease cardiac output. Tachycardia, just the opposite, faster than 100 beats per minute, so 100 to 160 beats per minute. You could possibly have reduced cardiac output there because it's going so fast it doesn't have time to fill. So both bradycardia and tachycardia can cause reduced cardiac output. They don't necessarily, but they could. So atrial flutter, 160 to 350 beats per minute, less filling time for the atria, and often reduced cardiac output. So a lot of times we want to say, how does this affect cardiac output? And there you go. With fibrillation, atrial fibrillation, rate over 300 beats per minute, uncoordinated muscle contractions, no filling, no output, cardiac standstill, this is a problem. Get your AED and call 911 while you're hooking them up to it. Premature ventricular contractions are additional ectopic beats that may induce fibrillation. The three different kinds of blocks, I don't necessarily expect you to know the heart blocks, but just know that the heart blocks are where the atria and the ventricles are not communicating. There's something wrong electrically. So in order to treat cardiac dysrhythmias, they have to figure out the cause. There are anti-dysrhythmic drugs that are effective in a lot of cases. Sinoatrial nodal problems or total heart block require the implantation of a pacemaker. There's also an indwelling cardiac defibrillator that may be implanted for conversion of ventricular fibrillation. So if somebody is frequently going into ventricular fibrillation, the implanted cardiac defibrillator can restart their heart when it needs to. So it detects the abnormal rhythm and it zaps you. So cardiac arrest is not when your heart gets arrested. It's cessation of all heart activity. There's no conduction of impulses, flat ECG. So lots of different things can cause cardiac arrest: excessive vagal nerve stimulation, potassium imbalance, either high or low, cardiogenic shock, drug toxicity, insufficient oxygen to the coronary arteries, respiratory arrest, again causing insufficient oxygen to the coronary arteries, or a blow to the heart. So we saw this in the 2023 NFL playoffs when one of the players on the Buffalo Bills got tackled and had a blow to the heart and suffered a cardiac arrest and had to be given CPR on the field, and he survived, got taken to the hospital, so that's good. But a blow to the heart can cause sudden cardiac arrest.